Good afternoon, everyone. Good afternoon, Chairperson and my fellow delegates. The topic of my paper presentation is Clinical Characteristics of Laryngopharyngeal Reflux and Role of Reflux Symptom Index and Reflux Finding Score in assessing treatment response in patients with laryngopharyngeal reflux, a longitudinal study in Tertiary Care Center of Central India. Laryngopharyngeal reflux is defined as retrograde movement of gastric contents into pharynx and larynx. The symptoms are vague and include dry cough, need of constantly clearing throat, dysphonia, and foreign body sensation. Reflux laryngitis is defined as a chronic laryngeal sign and symptoms associated with GRD. The role of GRD in causing extraesophageal symptoms is also increasingly being recognized. Classic reflux symptoms, heartburn and regurgitation, which are referred to as typical GRD, may be absent in more than half the patients with extraesophageal manifestations. The aims and objectives of my studies are to evaluate clinical characteristics of LPR and role of reflux symptom index and reflux finding score in assessing treatment response in patients with LPR, and to study the correlation between LPR and GERD using 70-degree laryngoscopy and gastroesophagoscopy. The materials and methods are: the study is done in Tertiary Care Center of Central India. It is a longitudinal study. Patients attending Department of ENT with clinical features and diagnosis suggestive of LPR are included in the study. Inclusion criteria is patients age greater than 18 years of age are included in this study. Patients presenting with symptoms and signs of LPR are included in this study. Exclusion criteria is patients suspected to have laryngeal malignancy and cases not willing to participate in the study are excluded. Sample size, there are 22 cases studied till date and study is ongoing. Study procedure: patients reported in Department of ENT with clinical signs and symptoms of LPR are included in the study. The reflux symptom index is a 9-item score, self-administered score. Each point rank from 0 to 5 according to severity, and RSI ranges from 0 to 45, that is worst score. This includes 9 items: hoarseness of voice, frequent clearing of throat, excess mucus, difficulty in swallowing, coughing, breathing difficulties, annoying cough, sensation of something sticking in throat, that is globus, and heartburn. Then RFS score is also evaluated with 70-degree rigid laryngoscopy or flexible NPL scopy. Findings were noted and scored according to score. This is 8-pointed score. This includes pseudosulcus, ventricular obliteration, erythema or hyperemia, vocal cord edema, diffuse laryngeal edema, and posterior commissure hypertrophy, granuloma, and thick endolaryngeal mucus. Reflux finding score ranges from 0 to 26, that is highest possible. Reflux finding score greater than 7 have greater probability having LPR. These are the images showing. First image is showing as ventricular posterior commissure hypertrophy. Second is thick endolaryngeal mucus, and third is hyperemia or laryngeal hyperemia or erythema. All patients who have LPR symptoms, that is reflux symptom index greater than 13, are sent for upper GI scopy, and it is evaluated for GERD according to Los Angeles classification. This is Los Angeles classification. It is graded according to mucosal breaks and thickness of mucosa involved in esophagitis. It is graded as grade A, B, C, D according to mucosal breaks only, and it is completely depending on gastroenterologist findings. Then in patients with clinical findings of LPR with RFS score greater than 7 or RSI score greater than 13, we are given a standard treatment protocol followed in our ENT department using tablet pantoprazole 40 mg twice daily before food, and treatment response was assessed by proper follow-up at 8 weeks. On follow-up visits, improvement in RSI and RFS score with PPI therapy was assessed. These are my study tools, that is self-made performa, by finding RSI index, then video laryngoscope and gastroesophageoscope. Study period was 2.5 years, and statistical analysis was made by scoring mean RSI and mean RFS value at beginning of treatment at 1 month and 2 months. These are my observations, that is demographic characteristics. More LPR cases are found in urban areas as compared to rural. Then chip complaints at the time of diagnosis. Most common complaint was found that throat pain, then followed by globus, followed by heartburn, and then others. Video laryngoscopic findings according to reflux finding score are most commonly there is in video laryngoscopy we found erythema, then followed by posterior commissure hypertrophy in 45% patients, then followed by thick endolaryngeal mucus in 36.36% patients. Esophagoscopic findings are graded according to Los Angeles classification. In esophagoscopic findings of LPR patients, we found that grade A esophagitis found in 27.27% patients, and grade B esophagitis found in 9% patients. In one patient, we have found esophageal candidiasis also. At the end, only LPR was found in 13 patients, that is 59.09% patient, and LPR associated with GRD according to esophagoscopy finding. 9 patients found with LPR with GRD, that is 40.91%. Results before and after treatment. Before treatment or at the time of diagnosis, mean RSI value was 13.5 and it was reduced to 5.18 after 2 month follow-up, and mean RFS value at the time of diagnosis was found 7.18, and after treatment or 2 month follow-up it is reduced to 3.41. According to paired T test, we have found that our study was significant and P value was less than 0.0011. Discussion. In previous studies, that is Anaghatul Joshi and Seman Selvan, mean RSI and mean RFS value was also decreased from 11.84 to 2.04 in Anagha ma'am study, and 7.92 to 1.52 in as according to RFS. In our study, mean RSI value was decreased from 13.5 to 5.18, and mean RFS value from 7.18 to 3.41. Our study underscores the importance of structural scoring systems like RSI and RFS to objectively diagnose and monitor LPR. While both LPR and GRD involve reflux, this study investigates the unique correlation between these conditions using gastroesophageoscopy and laryngoscopy findings. Suggests that ENT specialists should routinely evaluate GRD in suspected LPR cases. At the end, this study concludes that RSI and RFS score are valuable tools for monitoring treatment efficacy in LPR. These tools offer better specificity compared to relying solely on patient-reported symptoms or endoscopy. There is significant association between LPR and GRD, that is 40.90%, emphasizing the importance of integrated diagnosis and management. These are my references. Thank you.
Requesting Dr. Rajmane sir to hand over the certificate to Dr. Aniket and Dr. Emmanuel. Next is Dr. Abhijit Khandare. No? Done, sir. Now I would request Dr. Khandekar sir to felicitate Dr. Amit Pradhan sir and Dr. Anant Rajmane sir. Okay, thank you.